And we're going to start now and talk about obstructive diseases. Now, you already know a little bit about the obstructive diseases. We talked about these diseases that on the pulmonary function test, their airways collapse. And what happens when their airways collapse? Well, they obstruct the airflow, right, usually on expiration. And that's when you get the big hyperinflated lungs, the flattened diaphragmatic surfaces, right, and the wheezing that we sometimes hear. The wheezing is, you know, the patient trying to expel air out of the lung, and that's what we see on the X-ray, the flattened diaphragmatic surfaces and the hyperinflated lungs that are so consistent with these diseases. There's 3 diseases that we basically need to know about. It's the most important ones are COPD, the 2 COPD types, emphysema and chronic bronchitis, and asthma. And then we need to know a little bit about bronchiectasis. So let's look at those cases here. The first case is a 26-year-old woman with history of asthma who presents to the emergency department with 3 days of progressive shortness of breath. She takes inhaled albuterol and over-the-counter cold medication. Now, let me tell you a little bit about this. This is an important thing here. Now, this over-the-counter cold medication she took just the last day, right? And she noticed that even though that you know she had her shortness of breath, the last day or so things were getting even worse. When you see her respiratory rate is 28, her pulse is 110, she's afebrile. Her right nasal turbinate is edematous. There is evidence of wheezing throughout both of the lungs. After you give her supplemental oxygen, that's the first thing we do, what should we do next? So that's an important question. The answer is, you're going to see a little bit later, what do we do after we give the patient supplemental oxygen? We give the patient a bronchodilator. What's the best way to resolve the bronchoconstriction that a patient with asthma has is to give them short-acting bronchodilators. So the answer here would be to give the patient albuterol to resolve the bronchoconstriction. So a couple things on this patient, and then we'll talk about asthma and virtually go back to this case. Now, a couple things. When I evaluate a patient with asthma, what I want to know is what their prior history is. How many times they've went to the hospital, if they've ever been intubated. That gives me an idea of the severity of her asthma. And then I want to know, did she take any medications that may have exacerbated asthma, because this falls into a very specific category of asthma. Patients that have nasal polyposis and also have some sensitivity to aspirin, and there's cross-reactivity of aspirin with nonsteroidal. So about 20% of these patients also have cross-reactivity with nonsteroidal anti-inflammatory medications. But these patients generally have nasal polyposis, they have sensitivities to aspirin, some of them have sensitivity to NSAIDs, and they develop severe asthma. So I want to know that. And this patient, when she told me that, yeah, I took over-the-counter cold medication, and then, you know something, after I took it, my asthma got worse, and then I find this here, the edematous turbinate, right, nasal turbinate, I start to think maybe she's got the syndrome here, and these people have severe exacerbations. So that tells me, that this patient's not going to be easy. Then a couple of other things. I want to know from the exam, is she having a severe attack? And there's a couple of things that tell me that. Cyanosis, muscle retraction, right, from the exam. Silent lung, where you don't hear any wheezing at all. Those are bad signs that this patient's really having a severe exacerbation. And then we're going to talk about some lab findings like hypercapnia that we just talked about also just before, went to intubate and admit a patient to the ICU, that also mean a bad prognosis for asthma patients. But the first thing I do always in an asthma patient is I give them oxygen, and then after that we give them bronchodilators. The short-acting beta agonists like albuterol are the first-line drugs in the acute exacerbation in asthma patients. So the anticholinergics don't work so well. They don't work so well because they're long-acting. You don't get that short, that short-acting stuff that you get with albuterol. They're better with COPD patients. Aminophylline, right, we don't do anymore. unless the patient has status asthmaticus. Epinephrine and stuff like that, we don't do anymore. It's only with the most severe status asthmaticus that most of these cases, they're very rare now because we're able to treat the patient quickly with some other stuff that we're going to talk about with the albuterol, with the steroids. We don't have to use this medication. So traditionally, I know people have been using those in the past, and you read about them and you hear about using them, that they still use them in other countries, but we don't do stuff like that here. It's usually a beta agonist that we use, supplemental oxygen, and some of the steroids that we're going to use, and we'll talk about that stuff right now. So let's talk about general concepts about asthma. So asthma, the basic issue with asthma is it's an inflammatory process. The patient's lungs are hyperactive to some type of either allergens or infections, or sometimes we don't even know the causative organism or scenario, but these patients have hyperactivity more than normal people, and there's an inflammatory process that occurs. It's very important that you understand it's an inflammatory process, because the way you treat asthma, treat it, cure it basically, in a way, on a chronic basis, is through giving the patient anti-inflammatory drugs. So for example, we talked about before, what's the first thing that you do in a patient with an acute exacerbation? You give them bronchodilators. Yes, because the patient is very hypoxemic and is having distress, but that doesn't take care of what the disease is itself, and that it is inflammatory disease, and you have to give this patient anti-inflammatory medication to resolve that. It's always reversible. Asthma is always reversible. That is that's how you diagnose asthma, because on the pulmonary function test, in order for you to tell somebody they have asthma and to tell another physician that this patient has asthma, you're going to have to prove to them that they have a reversible disease, compared to chronic obstructive lung disease, where these patients, there's no reversibility, or that reversibility is very small. So, and how do you prove that reversibility? Well, one is the pulmonary function test. You give them bronchodilators and they reverse on the pulmonary function test. And then the other one is the history. The patient with asthma gives you exacerbations, and then in between, they feel great. They have no symptoms at all. In fact, they could have a total normal pulmonary function test in between the exacerbations. That's not the case with chronic obstructive lung disease. Patients with chronic obstructive lung disease have a baseline symptoms, and then when they have an exacerbation, they get worse. So these patients tell you, yeah, I'm always short of breath, I can't walk, I get short of breath, and then, yeah, the last couple of days I got worse after I got an upper respiratory tract infection. That's the type of history you get from COPD. Asthma, the typical asthma patient, is asymptomatic in between. The typical one. Not everybody, but the typical one. So the other thing that we see is that we usually get a history in asthma of early onset. So most of the cases that we see, usually they have the onset when they're children. And then, you know, it goes into adulthood. Now, you may hear this concept that a lot of patients, they get childhood asthma, and then a good % of them, maybe about 2/3 of the cases, they kind of outgrow their asthma. That's what people refer to. It's not really what they do, but basically, as they get older, most people get better. Childhood asthma in general is a better asthma just because more patients they get better as time goes by. The people that have adult asthma, these patients usually are the patients that didn't outgrow their asthma, so they still have it into adulthood. So generally speaking, if you take all patients across the board, people with adult asthma usually have a more severe, you're more likely to have a severe asthma when you compare it to childhood asthma. I'm not talking about individual cases, I'm talking about across the board. Having said that, asthma can be new onset at any age. Yes, most of the cases usually occur in childhood, and then you get a history that goes into adulthood, but cases have been diagnosed of clear-cut asthma in their 4th, 5th, and 6th decade of life. So You could have new onset asthma at any age group. It's usually early, but you could have it even later in life. And when this occurs, most of these patients have a more severe form of asthma than the ones that usually get it and have it through from children to adulthood. There's two types of asthma that we hear a lot about, but usually in the long run it doesn't really matter a lot. We hear about this atopic extrinsic asthma, that people get asthma exacerbations to different allergens in the environment. These are the patients that usually have urticaria, usually have other allergy symptoms, so this is referred to as extrinsic asthma. This has a better prognosis versus the idiosyncratic asthma, the intrinsic asthma, that basically there is no specific reason that these patients get exacerbation. I mean, they could get a viral infection or pneumonia, and that worsens asthma, but generally there's no specific reason that if these people, you know, come close to some kind of allergen, that this will precipitate asthma. The idiosyncratic asthma, the intrinsic asthma, is more severe than the atopic asthma, generally speaking. Now, a lot of our patients, you know, that's why this breakdown into idiosyncratic versus extrinsic asthma, it has fallen a little bit out of favor, just because in all our patients we look for allergens, we look for other things. Most of our patients have a little bit of both. They have a little bit of idiosyncratic asthma where we don't know what exacerbated their asthma in a given occasion, and then if you look closely, they have a little bit of extrinsic asthma. So, for example, if they come close to some, you know, allergens like, you know, animal hair and stuff like that, this precipitates their asthma. So most patients have a little bit of both. You know, the breakdown is not 100% makes clinical sense. They have asked us a lot of times, what are the most common precipitants of an asthma exacerbation? So the most common one across the board are lung infections. And what are the most common lung infections? The most common ones are viral infections. So it's more common to see asthma exacerbation in the winter time and a time of the year where people get viral infections and lung infections and so forth. Then the second ones that we hear about are drugs. Please be careful about aspirin and non-steroidal anti-inflammatory medications, because I told you about the syndrome that they have nasal polyposis. That's what this patient had, and had sensitivity to aspirin, and some of these patients have sensitivity to non-steroidals. Please be careful of that. Always get that from the history. And they may ask us, what are some of the drugs we don't want asthma patients to be taking? The answer is, I don't tell them to take aspirin. I tell them to keep away from NSAIDs in case they have the syndrome and we don't know about it. And then the typical one is the beta blockers. You hear a lot about that. And it's not an absolute contraindication to use a beta blocker in an asthmatic patient, but you have to be careful. You have to be careful, because no matter how cardio-specific the beta blocker is, they still cause some bronchoconstriction in these patients. So if you're going to use them for blood pressure control or heart failure management, be careful, because the patient may tell you, listen, I have more shortness of breath now, and it's not from the heart failure. Now it's because they have, you know, their asthma is worse and stuff like that. And then the third one that's also very important is exercise induced, right? So exercise, when you exercise, especially out in the cold, it causes bronchoconstriction. It causes bronchoconstriction actually in normal patients, but these patients, remember, they have hyperreactivity. And now they get, you know, asthmatic attacks when they exercise. They tell you, you know, I run a couple miles, and after I run, I'm coughing for 20 minutes. Or I go out in the cold and I start wheezing and I start coughing. So that's what they're talking about. They have to be a little careful. There's ways to manage these patients by giving them bronchodilators. We're going to talk about that in a little bit. So that's your general concepts. And let's talk a little bit about the presentation of these patients. So what's the presentation? When they have acute exacerbation, we're talking about the acute exacerbation, they develop tachypnea, of course, they're breathing quick, you're going to hear wheezing. Sometimes you don't even have to listen to their lungs, you can hear them wheezing, you know, from a couple feet away. Sometimes if the asthma exacerbation is severe, they develop accessory muscle use, so they're hunched over, and you could see the use of the accessory muscles. They have diminished breath sounds. That's usually not a good sign, because that if you develop totally diminished sounds, that's a silent lung. And some people say, okay, the patient's not wheezing, but they're not having any air movement in and out of their lung. That's a reason to watch that patient closely in case they need intubation. And then along with that, intercostal retractions and diaphoresis. These are all signs that this is a severe exacerbation. A paradoxical pulse is very interesting, because a paradoxical pulse is normal in all of us. That dip in the blood pressure is normal, and if you have less than 10 of paradoxical pulse is okay, but a pulsus paradoxus in patients with an asthma exacerbation, especially over 20, it means that this is a severe exacerbation. So right away, a couple things that you should know from this slide that tell us that this is an acute exacerbation: accessory muscle use, diminished breath sounds and silent lung, intercostal retraction, diaphoresis, and a pulsus paradoxicus of over 20. All these are ominous signs. You have to watch that patient closely, because this patient has a severe asthma exacerbation. And then in the chronic setting, now remember, in the chronic setting, these patients could have, if you're treating them well and they have mild or moderate forms of asthma, they could be totally asymptomatic. They could have no symptoms at all, right? Until they come in with the exacerbation. But they may tell us a couple things about atypical presentations in the chronic setting of asthma. They love to ask about these two cases. One is a young patient that presents with nocturnal cough. So there's this type of asthma that presents only with nocturnal cough. It's sometimes referred to as cough variant asthma. So these patients, basically, they wake up in the middle of the night, they cough, and then, after a while it goes away and they go back to sleep. For some reason, the exacerbation of asthma seems to occur at night. There's a couple of theories about that, but we don't need to know them for the boards. But it seems that these patients have more hyperreactivity at night. They go to sleep, they develop this cough. They may have some wheezing, but they don't know what wheezing is, so they don't describe that to you. And they tell you in the daytime they feel good. So nocturnal cough variant asthma, I want you to think about that next time you're evaluating a patient with nocturnal cough. So think about postnasal drip, think about reflux disease, but please also think about asthma in these patients. If there's a question about which one of these it is, do a pulmonary function test and confirm the diagnosis. And then the second one, which we already have hinted a little bit about, is this thing called exercise-induced asthma, where some patients come and tell you, I'm coughing after I exercise. And, what do you think about? Well, you think about this thing called exercise-induced asthma. Remember, with exercise, you become more hyperreactive. So these patients have a mini asthmatic attack, and they tell you, I'm coughing, and sometimes they tell you I'm wheezing. Some of the patients, though, don't know what wheezing is. So they tell you, I feel some lung congestion, I cough a lot, and then it goes away. And then when they come to your office, they're pretty much fine. They don't have any symptoms at all. So those are the presentations I need you to remember for the boards. Now, how do we evaluate these patients? Well, it depends what you're looking at. If you're looking at like the patient that we were just talking about, the case that we just talked about, in the acute setting, the evaluation is pretty straightforward. The ABG is very important because it gives us an assessment of the hypoxemia in this patient, and it also identifies patients that develop respiratory compromise and respiratory muscle fatigue, because it shows respiratory acidosis, so a drop in the pH, and an elevation in the PCO2. That's why you're really doing the ABG in an asthmatic patient, to see if this patient has hypercapnia, if the patient has respiratory acidosis. All those patients, if they do develop that, if they do have that, have to be in the intensive care unit and monitored very closely in case they need intubation. The typical ABG is one that shows, in an asthmatic patient, the typical ABG in an asthma exacerbation is one that shows respiratory alkalosis. Remember, they're breathing really fast, healthy patients breathing really fast, so they blow off their CO2, so they have hypocapnia, low CO2, and because of that they develop a respiratory alkalosis. That's the typical finding. If you got that, you're okay. But if you develop hypocapnia, please be careful. The chest x-ray in the acute exacerbation, they may ask us about that. Why do we need a chest x-ray in the acute exacerbation? Not to diagnose asthma. Most of the patients presenting with asthma exacerbation, they don't need a chest x-ray to confirm that they have asthma. What do you need a chest x-ray for? Well, remember what the most common causes are of asthma exacerbation? Lung infections. So the chest x-ray is there not to find the flattened diaphragms, the hyperinflated lungs, because you probably know about it already. You don't need that for that, but to see, to make sure that this patient doesn't have some kind of infection in the lung, like a bacterial pneumonia. So, for example, the patient coming in with an asthma exacerbation, I'm doing that x-ray, I don't want to see an infiltrate there because I'm going to have to add antibiotics in this patient to cover for bacterial pneumonia if I see one. The third one is a pulse oximeter. Now the pulse oximeter is usually, it doesn't give you the PaO2, but it gives us that part, the oxygenated part of hemoglobin, and it allows us to monitor oxygenation, not as definitively as the ABG does, right, but on a continuous basis. So, you can't do ABGs all the time. Remember, you have to do arterial sticks, and they hurt the patient and so forth. So you don't want to do that all the time. You want to do one, maybe do one, a couple of days later to make sure the patient's okay, but you don't want to do that frequently. How do you monitor, the oxygenation in a patient, from hour to hour, is to put the pulse oximeter on this patient and watch that. Now, it has some limitations. It gives you a percent. It gives you a percent. So you correlate that with a PaO2 that is not, specific. It's about. So, for example, somebody that has a pulse oximeter of 95%, I know their PaO2 is about 70, 80. It's not below that. Anything below a pulse ox of below 90, you have to be very careful, because that patient's PaO2 now is 60 or less. You have to be careful about that patient. That means that patient has severe hypoxemia. It also allows me to see what I could do with the medication. So if a patient comes in and has a pulse oximeter of 90%, and I give him bronchodilators, I give him the steroids and stuff like that, well, 2 hours later, I check the pulse oximeter again. Now the patient's at 95, 96% saturation. I know they're getting better with the medication, and I know I'm on safe grounds. So that summarizes the acute exacerbation, the evaluation in the acute exacerbation, like the case that we just presented. But in the outpatient setting, in the chronic phase, when the patient has minimal symptoms or sometimes is totally asymptomatic, that evaluation changes. The focus is different. The first focus is to confirm the diagnosis of asthma. That's the most important thing. Please be careful when they tell you about a young patient that has wheezing and has episodic wheezing and cough. Please don't assume always it's asthma. I've seen recent cases of patients that are young being diagnosed and carrying the diagnosis of asthma, and then we find out years later that they really have something else like COPD. And they had rare forms of COPD that start early in life, like alpha-1 antitrypsin deficiency and so forth. So please, every patient that has asthma and carries the diagnosis of asthma, you have to go back in their history and make sure everybody has had a pulmonary function test and confirm the diagnosis of asthma. What does diagnosis confirmed by pulmonary function test mean? It means that you have an obstructive pattern. The DLCO is normal because it's not like emphysema where there's something wrong with the alveolar membrane. And when you give that patient bronchodilator, you get a resolvement of the drop in the FEV1 over FVC in the obstructive pattern. So improvement after bronchodilator is the distinctive finding in the pulmonary function test with asthma. We also talked about before, and I want to make sure everybody understands here, that sometimes in a patient that has asthma, remember we said they could have a totally asymptomatic pulmonary function test because this is a reversible disease. By definition, it's reversible. It may be 100% reversible. So the patient comes in, does the pulmonary function test, everything is normal. The FEV1 over FVC is normal, the FEF 2575 is normal. So what do? You challenge him. You you do a bronchoprovocative test in this patient to basically cause a mini asthmatic exacerbation. And this test is called the methacolin challenge test, where you give the patient methacolin challenge and you see a drop in FEV1 over FVC and a drop in FEF 25. That confirms the diagnosis of asthma. Sometimes in the chronic evaluation, people look for other things like elevated IgE levels, like peripheral eosinophilia. The reason I have these 3 and 4 and I have a question mark after that is because they really don't mean that much in terms of the diagnosis of the disease and what we do for this patient afterwards. So really the only thing I want to know in an asthmatic patient is the history. I want to know how many times he's been to the hospital, she's been to the hospital, if they've ever been intubated, what medications they're taking, so you get a sense of the severity of the disease, and I want to know the pulmonary function test that they've confirmed the diagnosis of asthma before I go any further.